I'm blocking them.
Okay.
And
All of you all can see what.
I take the drink cloth, otherwise cannot see that.
Yeah. Today's class will be basically insertion of nasogastric tube. Before you go into it, I thought you need to know about the tube first and the gadgets first before actually we will go for the procedure. Fine. So nasogastric tube, as the name applies, it's a tube that is passed through the nose, goes into the oral cavity, and he has volunteered to be your patient today, and we will push the tube through to see how exactly it reaches that particular spot, and we will see how it goes by. It's okay, yeah? Next class is a rectal examination. Okay, so this particular tube, if you look at it, is a Ryle's tube. It comes in a sterile package. It comes in a sterile package. If you can't see, here you can. It comes in a sterile package, and which means that the whole process is a sterile process. Now, there are two names to it. This is how it is being spelled. This is called nasogastric tube or Ryle's tube. Nasogastric tube, based on from where to where it reaches or where it goes to where it reaches, it is called as NG tube, nasogastric tube, Ryle's tube, whatever. It comes in various sizes. Here, the size is very easy. Smaller the size, it is nothing to do with the length. There will be slight difference with the length, slight difference with the diameter of the tube. Bigger the number, slightly larger is the diameter, slightly longer is the tube. Is that okay? If you look at it, how do you know which is the tube size is? Can you see a word which says size? Can you see that? Can you see that word which says size? That is what it means. And this particular tube is 14 size. Now, if you peel off and you see the tube, this is how the tube looks. One end of it is slightly broader. One end of it is slightly broader, which has got a cap as a protective mechanism. Whereas the other end of the tube is a blunt tube, but it is packed with some material, and this material will be lined along the wall of the tube, all along its length. All along its length. Have a look at the tube that you are holding. If you look at the color of the plugged material at the blind end, the same material will be lined all along the length of the tube. And what is this material? This is a radioactive material. What do you mean by radio opaque material? Not radioactive, radio opaque. What does that mean? When you push the tube through and you want to know whether the tube is in place, and if you have to confirm, only method we confirm, I use the word confirm 100%, is by X-ray. So when you take an X-ray, you won't see the tube as such because rays pass through. But this line being opaque is the line that you will see, and you can trace it along the chest X-ray to see that line reaching the stomach. So that confirms the tube in place. And that is why you have this plugged material at the blind end and a thin line of the same material running all along the wall. The colors will change. For some it is blue and the other is various colors as well. So it depends. Is that okay? Again, I repeat, smaller the number, smaller the diameter. Why so? Pediatric age group, you will have to sit and decide which tube do you want. Adults, you pick and choose. Somebody who's in a Western person compared to an Asian person, Western person, you need to choose a little bigger tube so that it tightly packs. It's not like it has to be sealed because of the nature of the size, physical size of themselves when compared to us. So 14 and 16 are the adult sizes, which is predominantly used in our Asian setup. If it's a Western setup, you choose one size more. That's more than enough. Is that okay? So the purpose of this tube is basically to drain the contents of the stomach and to use the content for various diagnostic purposes. Number one. Number two, you're taking me for surgery today, and you don't want my gastric juices to contaminate after anesthesia your sterile environment, which is there in the operating theater. So you push in a tube and this will drain all the gastric juices out so that nothing happens and it falls into the bag. That is number 2. Number 3, even during anesthesia or a person who is unconscious, what will happen is gastric juice continues to form. When it forms, what happens is the chances for it to regurgitate, chances for it to come up and find its way into the respiratory passage is very high because of the nature of the person. Because he doesn't have much of peristalsis, he may not breathe in and breathe out well, and he may not swallow his own saliva. All that put together will aspirate the gastric juice because of his position. He's not going to be standing erect, he's going to be reclined or lying flat. In all the conditions, gastric juices will find its way in the opposite direction, and it can go into the respiratory passage and it can lead to a condition called as aspiration pneumonia. In order to, in a person who is going for surgery, in a person who is bedridden, we choose this tube so to avoid aspiration into the respiratory passage. Is that okay? Fourth condition, when somebody consumes a poison to kill themselves, commit suicide, you want to wash the contents of the stomach, gastric lavage. Maybe we may not use this too, but this is also used because that tube is slightly bigger. Because we want quickly to evacuate the whole thing, this will take a little longer time. We don't want that to be absorbed, so we put in a slightly bigger tube, the same way as we follow, but that's a slight difference. There is a difference, but this tube can be used. Last purpose is, if you want to take 2 more purposes, if you want to take the gastric juice and send for investigations, if you want to rule out certain things, make a diagnosis, yes, you push the tube, aspirate the gastric juice through the tube, and you send for a diagnosis. You must have read in your physiology, it is an acidic base, not a basic type. It's more of an acidic in nature, so you will have to do a dipstick method to find out based on the color change you can declare whether it is gastric juice or something else. Last but not the least, there is one more course as well, where in which if you want to do this, normally what we do is, if a person who has issues with esophagus, is a person who has issues with eating, for example, anybody who's got a cancer of the esophagus luminal cavity this is the luminal cavity, a cancerous growth completely occludes the luminal cavity of the esophagus, patient will not be able to eat anything. So in such individuals, or in a person who is in the coma, who can't eat by themselves, you have to feed them. So for such purpose, or an elderly person who can't swallow, or a person with any neurological defect who can't swallow, we push the tube, and this tube, the purpose will be, it becomes for feeding purposes. So it can also use to feed as well. Is that okay? Multiple reasons, it's all there. You will be able to understand why are we using it. This is the purpose. So this is how the tube looks like. Remember, it will have a blunt end, because there are multiple tubes that you will be looking at as we move from one system to another system. Register how it looks. Remember, it has got a blunt end on one side, which is plugged with radio opaque material. It is plugged with a radio opaque material. Proximal to that, you will have multiple holes for the content to be absorbed, or now the contents to pass through if you're trying to aspirate. Is that okay? The same plugged material will be lining like a thin line along the wall of the tube throughout its length. Is that okay? On the other side, this is the tube that will remain outside, and you use this end for various reasons. Either you can connect this particular tube. If you want to aspirate, you can aspirate. You can remove this, and imagine that you have a cup of porridge or whatever, you pour it, and it will reach the respective side. Is that okay? Fine, everybody? So this is how a Riles tube looks like. Register this, register this, register this, because you will have 3 more tubes that you will be seeing in the rest of the systems. Generally, you should not confuse between that. So the criteria to identify, this is the Riles tube. It's a long tube, point number 1. On the blunt end, you will have a radio opaque material. And this radio opaque material, proximal to it, you will have multiple holes for the gastric juice to enter into the tube. Then the same radio opaque material will line along the length of the tube as a thin line. This will help you to confirm whether the tube is in place or not. Is that okay? Right? So this is with the tube. Now we will go back to the procedure as such. How do we do it? After seeing, we have already seen the indications. Now we will see how exactly we can insert the tube. Is that okay? Contraindications, we will come back to that. Volunteer, volunteer, volunteer. Okay, guys, give me a minute. We will get our volunteer. Volunteer is here. Hold on, hold on, hold on. Down, lie down, or lie down, lie down. Lie down. So now we are going to the actual area, actual procedure as such. Is that okay? Right. Good morning. Thank you very much. I'm Narendran. I'm supposed to show your classmates that how do I push the tube through to your nose to reach the stomach so that we can aspirate the contents and send for investigations. All you have to do is you will have to sit up and I will tell you how. Is that okay with you? Yeah. Okay. Do you have any issues as such, like difficulty swallowing or anything? No. Did you have breakfast in the morning? Yeah. What was it? Sorry? Okay. Just to know what you had eaten. So when I aspirate, I will see something of it so that I will know. So first is position. He has agreed. Position is, remember, position is called as high Fowler's position, which is not 45 degree, not 90 degree, somewhere in between. Choose whichever it is. So how do you do it? Patient doesn't have to get up. Patient can lie down. This is somewhere 45 degrees. This is high Fowler's, which will be position, high Fowler's, not 90, not 45 degrees. First one. Second, patient is wearing a face shield. We can remove it. Now I want you to shut one nostril. I'm not removing the face mask. I want you to shut one nostril. Inhale. Just what you do is shut one nostril. Shut one nostril. Breathe in. The other nostril. Breathe in. Why do I do that? Because this tube has to be passed through the nose to reach the stomach. I want to pick and choose a nostril which is not packed with secretion. Suppose if a person has got upper respiratory tract infection, that particular part of the nasal cavity, left side or right side, will be blocked. So if it is blocked, I will choose the one which is patent. So you know the particular sound, it will have a bubbling kind of a turbulent sound where you can hear the air passing through. When there is a narrow passage because of the secretions, it is loud enough for you to hear it. But in him, let's confirm. Aspirate, not aspirate. Breathe in. The other nose. Is that okay? There's hardly anything. You need to come closer to hear it, which means there is no turbulence in the sound. And the nasal passage is here. I can choose left nostril or right nostril to push the tube. Point number one. Suppose if there is a secretion in there, somebody's got an upper respiratory tract infection, and one of the noses plugged with secretions. What do? I choose the one which is patent. If both the noses are blocked with secretion, I'll get the guy to go and blow the nose a few times so that the passage is clear, and then I will do it. If still it doesn't happen, I'll have to do a nasal, insert a nasal decongestant, clear the contents of the nose, and then I will do it. Is that okay? These are the few things that is extra, which you need to understand. Is that okay? Position, number one. Check whichever nostril is patent and choose the nostril that is patent. And how do you do it? You just saw. Is that okay? Now, things that we need. You need a sterile tube. Sterile tube. Sterile Riles tube. I'll leave it here. Number one. Next, you will still need a cup. I don't have a straw. I need a cup with a straw. And this cup will contain water. I need a cup with water and with a straw. Is that okay? But unfortunately, I don't have one. Next, I need a syringe as big as this, and we call this as 2-May syringe. Is that okay? Right. Once we have all this ready, I need to have a stethoscope as well, also to find out whether the tube is in place or not. Is that okay? Confirmation is different. To know whether the tube is in place, which is an indicator for me as a physician at this point in time, I need to auscultate to find out whether the tube is in place. Okay, so these are the things that you would need. A cup of water with a straw, 2-way syringe, stethoscope, appropriate size Ryle's tube, patient ready to go. Are we okay? I've already got the consent. I check whichever nostril is patent enough, and then I will insert. Once the tube has been, somebody has opened it for me, and this is how the tube looks. If you look at the body of the tube, it has got a lot of graduations that you say, but basically what happens is you're not looking at the measurement that is there on the body of the tube, because the moment it reaches the stomach, you will know gastric juice comes out, and automatically you will know that you have reached the target. It doesn't mean that it has to reach this particular marking to confirm whether it is in place or not. Is that okay? It doesn't matter much, but when you aspirate, you need to get the gastric juice, and that confirms whether the tube is in place. So that confirms that that is the depth that you have to push the tube through. Is that okay? So it does not rely on the numbers that you see on the body of the tube. Is that okay? Right. One. Next, since he has already done it, I'm not going to remove now. So all I would do is get the patient to sit up, and when I choose to insert, before I choose, I will take an anesthetic spray plus it has a little bit of anesthetic material, plus it has a little bit of a drug so that it doesn't bleed. Is that okay? So what do? Is we just insert. It will be like a small bulb with a drug in it. It will be plugged into the nose, press it so that the fumes goes into the nose, numbs the area of the nose. Likewise, we get the patient to open the mouth, we numb the oropharynx. Why? Because the patient is not supposed to have a gag reflex when you push the tube. You know what is gag reflex, especially when you brush your teeth and it happens to hit the posterior part of your oral cavity, is that sound that we get. We don't want that. That will propel the tube out. Is that okay? So once having numbed it, first position, pick up whichever nostril that is patent, number 2. Before that, you gather all the gadgets. Third, anesthetize the nasal passage as well as the oral passage, and then we are ready to go. Remember, blunt end of the tube is what that is inserted. Remember, when you're holding the blunt end, do not push the tube towards the cranial cavity. Because of this particular position, you will have to see the floor of the nose through the nasal passage. If you go, the nasal cavity will be like this. Do not go up. You go along the floor of the nasal cavity. The floor of the nasal cavity will be here. So when you push it into the nose, it should not go up. It should go but towards the floor. Again, I repeat. I hope you understand what I'm trying to say. When you push it into the nasal passage, do not push it right up to the cranium, towards the cranium. As the tip enters into the nasal passage, guide it along to the floor of the mouth. As you push the tube, the moment it reaches the oropharynx, the patient will have that gag reflex kind of thing. Patient will kind of feel the tube that is there within the oropharynx. Stop. All you have to do then, give the patient a cup of water with a straw, and instruction is take small sips of water and swallow. So as he swallows, I'm not pulling the tube moment he has the gag reflex when it reaches the oropharynx. The moment he starts sipping on the fluid, that is the time I will try to push the tube through. Every time when he swallows, I push the tube through. I wait for the swallowing to begin, I push the tube through. Why? When the patient swallows, the pharyngeal muscles will grab the tube, and me pushing it will guide it into the respiratory, in the right passage. If by any chance, if my synchronization is not with the act of swallowing, chances for it to go into the respiratory passage is high, which we don't want. Suppose by chance it goes into the respiratory passage. Patient is trying to swallow. I quickly push the tube, enthusiastically I push the tube, but unfortunately it finds its way into the respiratory passage. How do you know it has gone into the wrong passage? You will have signs which the patient can show. Patient will not be comfortable. He's going to hold my hand, or he's going to tap my hand off. Or he will pull the tube by himself because he's making him uncomfortable. he can't breathe. That's one group of people. Another group of people will try to manipulate, try to hold on because doctor has pushed the tube through. And he expects that this is what it is, where even though it has passed to the wrong passage. What will happen? They'll become breathless, they'll become blue-black, sometimes a bit of cyanosis, they'll feel a little giddy. All that is a sign for you to think, hey, it is not in the right passage. This right passage means it has to be in the esophagus. It can't be into the trachea, larynx and the trachea. If it is into the larynx and the trachea, signs that you look for while you push the tube will be is patient becomes cyanotic, patient becomes breathless, patient becomes kind of giddy, patient becomes kind of eyeballs and all will be roving upwards. That kind of a feeling that is one group. The other group will just tuck your hand off. The other group will be able to tell you, not tell you, they will that they will make gestures, so you will know that it is not in the right tube. Another group will pull the tube free. So all these are signs to know that it is in the wrong passage. Now, synchronization with the act of swallowing, you quickly push the tube, push the tube, push the tube, and moment you reach a particular length, normally as you push the tube and it reaches, probably I will say, if you look at the measurement, roughly about, I should say about 3/4 of the tube goes through, if you have reached, and the tube is in place. All you would do now will be is, imagine this was the tube that was hanging from his nose. Is that okay? Imagine this was the tube that was hanging from the nose. This was the tube that is into the stomach. Now, all I would do is take a 2 ml syringe or a 10 ml syringe or whatever, take some air into it, wear a stethoscope. And once I wear the stethoscope, I will connect the 2 ml syringe. I'll place the stethoscope in the left hypochondrial region where the stomach is, and I'll push this air with great force, one shot. What will happen if this end of the tube is here and my stethoscope is on top of it to listen? I hear a pop noise if the stomach is empty. If there is gastric juice, I'll hear kind of a bubbling sound. That confirms whether the tube, not confirms, that tells you that the tube is in place. Once I push the air through, then to know that whether the tube is in place, again, second step, I can aspirate to see the color of the liquid. 2. Third, I can take the same liquid, I can check whether it is an acidic or a basic liquid. Acidic stomach, the stomach juice. Is that okay? These are the few methods to tell you that the tube has reached its target site. Is that okay? Now, you want to know whether the tube is in place, you want to confirm whether the tube is in place. All you have to do now is send the patient with the tube to the X-ray department. You take an X-ray, you will find the line of the tube there, that particular radiopaque material in an X-ray to see whether the tube is in place. Is that okay? Fine, everybody? Now, I'll stop here. I have a video for you to watch. I want you to watch the video. It takes you through the same thing that I have told you. Some of the things which I have mentioned is not there in the video, so I thought I will do this first so that you can have a look at the video. Is that okay? Kindly blend what was told to you along with the video content of the video. The job is done. Is that okay? Thank you. Don't worry, you thought I'm going to push the tube. Okay, I'm going to play the video.
This is a video in clinical medicine from the New England Journal of Medicine.
People online, you can hear me?
Yes,
This
sir.
is a video in clinical medicine from the New England Journal of Medicine.
Supposed to mute, is it? I mute.
Common indications for nasogastric intubation include decompression of the GI tract in patients with bowel obstruction and gastric emptying in intubated patients to prevent aspiration. NG tubes may be placed as an adjunct for the delivery of oral agents such as activated charcoal or oral radiographic contrast media. NG tubes are often placed in patients with suspected upper GI hemorrhage. However, the sensitivity and negative predictive value of nasogastric aspirates for detecting active bleeding is suboptimal, and the absence of bloody return cannot be relied upon to rule out hemorrhage. Nonetheless, nasogastric intubation may be useful in selected patients. Evacuation of blood and clots from the stomach may facilitate the endoscopic visualization of the gastric and duodenal mucosa, and the return of bright red blood does provide prognostic information. Nasogastric intubation and gastric emptying may be beneficial in patients with severe pancreatitis and associated ileus. However, it has been shown that NG tubes are not beneficial and in some cases detrimental in patients with mild or moderate symptoms. Nasogastric intubation should be avoided in patients with significant maxillofacial trauma, as the tube may enter the cranial vault if the thin cribiform plate has been disrupted. The procedure should also be avoided in patients with known esophageal abnormalities such as recent caustic ingestion, diverticulae, or strictures, as they are at high risk for esophageal perforation. Since nasogastric intubation may induce emesis, patients who are unable to adequately protect their airway should be intubated with a cuffed endotracheal tube if the procedure must be performed. Begin by gathering equipment you will need. This will include gloves, a protective gown, and face shield, an appropriately sized nasogastric tube, vasoconstrictor spray, and a topical anesthetic such as benzocaine or lidocaine solution with an atomizer. Obtain a lubricant, a glass of water with a straw, towels or blue pads, a 60 cc catheter tip 2mm syringe, a stethoscope for tube confirmation, tape, and a wall suction setup. Have the patient breathe in through each nostril to assess which side is more patent. Premedicate the nasal cavity with a vasoconstricting spray such as phenylephrine or oxymetazoline. Anesthetize the nasal cavity with a topical anesthetic such as 4% lidocaine or topical lidocaine jelly. The posterior oropharynx should also be anesthetized with lidocaine or topical benzocaine spray. Nebulized lidocaine may also be used. The proper depth of tube insertion is approximated by measuring the distance from the xiphoid process to the angle of the mandible and then to the nostril. Lubricate the distal tip of the nasogastric tube with surgical jelly or viscous lidocaine. Position the patient sitting upright in the sniffing position. Insert the tip of the nasogastric tube into the nasal cavity and slowly advance it posteriorly, parallel to the floor of the nasal canal. The tube should not be directed upwards. In this endoscopic view of the nasal cavity, note that if the tube is passed in an upwards fashion, it will reach a blind recess at the middle turbinate. When the tube is passed parallel to the nasal floor, it reaches the posterior nasopharynx without difficulty. Continue to pass the tube posteriorly. The patient may gag once the tube reaches the larynx. Temporarily halt the advancement of the tube and ask the patient to begin swallowing sips of water through a straw. Coordinating advancement of the tube with the swallowing mechanism facilitates passage of the NG tube into the esophagus and prevents entry into the trachea. This is a fluoroscopic view of a nasogastric tube being inserted. As the tube reaches the level of the larynx, advancement is temporarily halted. The tube is then inserted as the patient swallows, and once past the larynx, is rapidly advanced. Note that in this endoscopic view of the larynx, the trachea is frequently open and may be accidentally intubated with an NG tube. Note also that as the patient swallows, the laryngeal apparatus arises and the epiglottis covers the glottis, preventing tracheal entry. Once past the larynx, the tube may be inserted rapidly to the predetermined depth. Check the black markings on the tube to confirm proper depth of insertion. Assure that the patient is in no respiratory distress and is able to speak. If the patient is unable to talk, is in respiratory distress, or if respirations can be heard through the tube, it should be removed immediately, as tracheal intubation has likely occurred. Attach the catheter tip syringe to the main port of the NG tube and insufflate 30 cc of air while auscultating over the epigastrium. A gurgling noise should be clearly audible. Using the same syringe, aspirate the NG tube and ensure that it fills with gastric contents. It should be noted that auscultation and aspiration may occasionally provide false positive results. Therefore, radiographic confirmation of tube placement by visualizing the NG tube's descent below the diaphragm should be obtained prior to infusion of any substance, such as activated charcoal or oral contrast media. The tube should be secured to the patient prior to transport to the radiology suite. Take a 5 to 7 centimeter strip of adhesive tape and tear it vertically for 1/2 of its length. The wide section is placed across the patient's nose, and the two tails are then wrapped in opposite directions around the NG tube. You may now connect the nasogastric tube to suction. Turn on the suction and adjust the vacuum force as desired. Minor complications of NG tube insertion include epistaxis, sinusitis, and sore throat. More serious sequelae include esophageal perforation, pneumothorax, aspiration, and, rarely, intracranial placement.
Okay, unmute.
They can hear me or not?
You ask them now. I have already unmute.
Yep, can hear you.
Okay, right. I'll just go through the actual step very quickly and we will be done. Is that okay? Good morning. I'm Narendran. I'm supposed to push in a tube through the nose to do some test with the contents of the stomach. I hope it's okay.
Yeah.
Is that okay? Patient is agreed. Position of the patient, high, powerless. Next, I want you to shut one nostril, breathe in. Likewise, breathe in through the other side. So the nostril is straightened. I can choose any one of the nostrils, number one. Next, the required gadgets that I need is ND tube, a cup of water with a straw, number two, a 2 May syringe, 3, and that's it, maximum plus a stethoscope. Is that okay? Now, it comes in this tube comes in a sterile package, and I will choose an ideal size, which is 14 or 16, which is right for an adult. Now, one of the things that you need to remember is we need to prepare the patient now. Next, I will take an anesthetic material, pump it into the nose, into the oral cavity, and this anesthetic material has two things apart from anesthetic material. One, the other thing is vasoconstrictor. In case if it bleeds, it tends to suppress that as well. Is that okay? So the next part that we will have to do is how deep do you have to go? The blunt end of the tube, leave it at the level of the ZT sternum. Other end of the tube, go up to the earlobe, and from there you come up to the tip of the nose. You don't touch because this is a sterile tube. You just have to give a rough estimate. That particular end, you mark it. Again, I repeat, blunt end, I will do it from the side. Blunt end at the level of the ZT sternum. The other end goes up to the earlobe. From the earlobe up to the tip of the mouth, tip of the nose, and make a mark. And this is the depth that you have to insert, which means this mark comes up to the nose. Is that okay, everybody? Once that is done, some people lubricate the tube before they push through. Choice is yours. Is that okay? If you can lubricate a little bit, remember, one of the point is never push the tube up, push the tube facing downwards along the floor. As you push the tube, it reaches the oropharynx, which is a common passage for GIT as well as respiratory passage. Patient will have that initial gag reflex. Stop. Take a cup of water with the straw. Ask the person to sip small volumes of water and swallow. As he swallows, that is the time you quickly have to push the tube through till that mark that was made on the tube. Is that okay? Once it reaches there, stop. Take the 2 May syringe, connect it to, imagine the tube was around the patient like this. This particular end, you take the 2 May syringe, take about 10 to 20 ml of air, connect it, wear a stethoscope. Leave it at the region of left hypochondria or epigastric region. Push air forcefully and listen to the sound. You could either get a pop sound or you can get a bubbling sound of the liquid that passes and the air passes through the gastric juice. Is that okay? This will tell you that the tube is in place. After doing that, you can aspirate the contents to see the nature of the content to know that this is gastric juice. Third, the same juice you can do litmus. You can check for the acid or a basic test, acid test or a basic test. You can dipstick. You can dipstick method. You can choose to find out whether it is an acidic liquid or a basic liquid to find out whether it is gastric juice or not. Okay. Last one. All this will tell you whether the tube is in place. The last one, to confirm, to send the patient for an to the X-ray department to look for the radiopaque line that reaches the stomach. Is that okay? That confirms the tube in place. Remember, this is how it is being done. Now, if you want to know whether the tube is passed through into the right direction or into the right passage, as you push the tube, you will have to look for certain signs. Patient will have incomprehensible words. Patient will tap your hand off. Patient will pull the tube. Patient will find breathless. Patient will become blue, cyanotic as well. All that is a sign that the patient is in the respiratory distress, and you know that the tube is not in the gastrointestinal passage. It has found its way somewhere else. Is that okay? If that is the case, you have to pull out. Is that okay? And you have to redo the whole process. Probably we won't use the same tube. We will have to use another tube. Is that okay? Now, one of the complications is you can create a false passage. You can injure the passage as you push the tube. It starts from the nose or internally, especially the nose patient will tend to bleed. The worst passage, two complications. It's not a complication which can, if you are not skillful, if you're not mindful that the tube cannot go pointed upwards. If you point it, it can go into the cranial cavity as well, which is the last thing that can happen. It can, by default, easily it can find its way into the respiratory passage if it is not synchronized with the act of swallowing. Is that okay? That is what you need to be mindful of. Fine, everybody. Now, one of the most important contraindication where you cannot push the tube through the nose is somebody who comes with a road traffic accident with the facial bones being shattered. Don't try this method. There are other methods which we will use to push the tube through, but not through the nose like what I told you we saw right now. Is that okay? Fine, everybody. This ends the class. Anyone? Any questions? People online. Anyone? Any questions? We'll finish them first.
No questions from me, doctor.
Okay. Okay. It happens. It happens. Is that okay? People here. Anyone? Any questions? Okay then. Thank you very much. We are done.